Hi, this is Dr. Bill Kottemann. I'm looking forward to presenting to you one of the more challenging cases that I've treated with aligners and with TADs in my practice. I've been using aligners now for over 20 years in private practice and have been in practice for 41 years. So I have seen quite a bit. But as you'll see with our patient Roberta here, she presents a very atypical kind of problem. She's class 2, a 60-year-old. She has a history of osteochondroma in her right condyle, which means she had a large overgrowth, making the ramus height effectively longer over a number of years for her. Following the asymmetry that was noticed, she then had a condylectomy to cut it back down. Well, the problem that happened is that with the cut down condyle, now she's very deficient in height on that right hand side. And so, as we shall see, she has a posterior open bite on the left side, as well as a large anterior open bite and a cant of her maxilla. She did have previous orthodontics with 4 bicuspids extracted. So if we look at Roberta, you can see she is really essentially only touching on the molars and bicuspids on her right hand side. And so again, what happened is when she had the excessive condylar growth due to the tumor on the right side, as a resultant compensation, the posterior teeth super erupted to try and maintain contact. And so then the procedure was performed, and you can see they literally just buzzed off that condyle. So now our total ramus height is much shorter on that right side than on her left hand side. And you can see, looking at her ceph, the discrepancy here on her gonial angle, where we have the much shorter right hand side. So our treatment plan is, and her chief complaint, by the way, of course, was very much difficulty in chewing. So our treatment plan is we want to intrude that posterior segment with TADs and attaching to the TADs vertical elastics, extrude her anterior teeth, warning her that vertical elastics would probably be needed. And I also, being a pessimist a little bit, wanted to say that there was a good chance that she may need a secondary surgical procedure to get some ramus height back on that side. So in the ClinCheck, all I put in initially in the treatment form was to intrude the posterior teeth and extrude the anterior teeth to close the open bite. And then I always like to dial in a few overcorrections for rotations and in and outs at the very end of treatment to overtreat those rotations and in and outs. And even today, we still need to describe those overcorrections to the technician. So the first ClinCheck that we got back shows the need for a number of improvements. And so let's take a look and see what might be needed to make this a little bit better treatment. Number one, the velocity. There's only 15 aligners. Now this was back in the era of 2-week treatments, but nonetheless very, very quick. So let's look at the movement. You can see we've got the intrusion, and that went very quickly. We have the intrusion of the upper posterior teeth on the right side, and then we see the bite jump, which of course we know in reality the mandible would come up to close. Now, one important point there, and this is something that they are doing some experiments with a virtual articulator, but when we see this bite closure from the intrusion, notice it's straight up and down. In the mouth, of course, there would be auto rotation around the condyles, so there would be some forward movement of the mandible which is not illustrated here. So a point is, whenever you have posterior intrusion occurring in a case, expect the AP to change. In this case, it's a good change because she's still class 2. So in other words, I would expect to see her class 2 somewhat improved when we see the bite jump as far as the result of the intrusion. So we do, number one, need to increase the velocity, increase the number of aligners by slowing down the velocity. And then I'm going to adjust a few attachments as well. We look at our left-hand side, by the way, and there is some intrusion taking place on that lower left. So this ClinCheck is going to go back to the drawing board, and we just simply told them slow the velocity by adding 8 more stages. And then with the 3D controls, I adjusted a number of the attachments. And so now we have a much better ClinCheck in that we've got a more realistic velocity, and we also have some attachments that will grip a little bit better. So if we look at this, we can see we have basically what look like extrusion attachments, horizontal attachments beveled on the gingival, so that we are gripping the teeth, and we're extruding the anteriors, as you can see, a little bit, as well as intruding the posteriors. And then if we look at our overcorrections, they are just to deal with the rotations. You can see how that upper central was rotated mesially in. It will be slightly rotated mesially out when we build in those overcorrections. And there are also some subtle overcorrections in the lower arch. We notice the labial position of that lateral, and so now it's slightly lingual in the overcorrected state. So we went ahead and approved this ClinCheck. So how are we going to get there? That's where the TADs come in. So we started actually later in treatment than I should have done. About halfway through, we were first just monitoring our progress, and then I decided to add an upper and a lower TAD. And just to make sure that it in fact would be an effective treatment modality, we were initially having a rubber band go from the TAD directly to the buttons on those teeth. And we noted then after a few months that we're seeing great intrusion of those bicuspids. And we can see also certainly how the bite is starting to close down now, as well as we're getting near the end of our first batch of aligners. And so here you can see the aligners in place, and you can see that we are actually getting a little intrusion out from underneath the aligner, showing that we're overpowering the attachment and in fact getting good intrusion of the teeth. The aligners are fitting very well everywhere else.